Good afternoon. My name is Gary Strichtartz, and I'm pleased to be able to talk to you about updating medical cannabis for treatment of pain. My one disclosure is that I'm a paid consultant on a project funded by FlavoCure. Chronic pain is a global problem. It steals people's lives. It's poorly treated or treated not at all, and particularly in developing and low-income countries. It's also a major contributor to the global opiate epidemic. Pain is an experience. It's usually initiated by some tissue-damaging stimulus. It involves physical and emotional responses. It's shaped by our biology, by our genes, by our family situations and our culture, strongly by past experiences and our current state of health, including, importantly, our mental health. Our sense of ourselves determines how we deal with pain. We distinguish two different types of pain. Physiological pain, that immediate response to a tissue-damaging stimulus, something that we sense would harm us, such as grabbing a hot pan on the stove. It's an important element for survival, and we learn from it. We don't grab that hot pan again. Describe it by objective criteria. Is it stabbing pain, burning pain, dull throbbing pain? How intense is it? Where does it come from? Is it constant or changing over time? How long have we had it? Months, years, days, minutes? And then importantly, there's a subjective component, the component about how we feel about it. How much suffering are we having from this pain? And if there weren't this affective component, this emotional component, then pain wouldn't be very, very important for us, or as important as it is. But it's the suffering that affects our lives. The second kind of pain we call pathological pain, and importantly, this has no survival benefit. It's experience from stimulus that's usually not painful. A light touch, for example, on the back of someone who's just had a bad sunburn, instead of being a pleasurable touch, is now a painful experience. It's often chronic and can last for months or years. Importantly, it's resistant to the treatments that are effective in physiological pain. Pathological pain is the pain that causes us deep and enduring suffering. It's the pain that erodes lives. What are the common causes of chronic pathological pain? Diseases such as diabetes, cancer, and cancer chemotherapy itself can cause consistent pain. Physical trauma, injuring a nerve, spinal cord damage, fracturing a bone, having a visceral disease such as gallstones, amputation that can lead to phantom pain, the perception of pain coming from a limb that isn't even there anymore. Surgery can often have pain that lasts afterwards for many months, sometimes years. And psychological trauma can indirectly cause pain. And this is particularly true in childhood when the brain is developing. As I noted before, pathological chronic pain is resistant to the drugs and other treatments that are effective on physiological pain. And chronic pain lasts much longer than the apparent injury, disease, or trauma, well after apparent healing has occurred. And why is there this resistance to the drugs, and why does it last so long? If we knew the answer to that, we could begin to develop treatments. One aspect of pain that's different from other sensations is sensitization. Other sensations, such as touch or sound or sight, if they don't change, we usually accommodate to them. We stop paying attention to them. It's the changes that cause us to pay attention. But pain, if the stimulus continues, the pain continues, and in fact, the pain gets worse. So an intense pain, repeated or constant, sensitizes the nervous system, causes changes in the peripheral nervous system, the nerves that go out to your skin and bones and to your organs, and importantly, causes changes in the brain, in the neural connections and synaptic activity. This so-called neuroplasticity is there, and that gives us an enduring change. The brain of someone who is experiencing chronic pain is different than it was before they have the chronic pain. And so the important questions are, what treatments will suppress these heightened pain responses? And can these neuronal changes be reversed? This leads us to the possibility of medical cannabis. And cannabinoids, these compounds that come from plants, they affect different parts of the brain and other parts of the body. They can alter how we feel, our mood, well known to do that, and they can have an effect on objective pain also. But because pain is such a complex phenomenon, understanding how cannabinoids work is also a complex issue. Let's talk a little bit about cannabis pharmacology. We know that there are specific receptors called CB1 and CB2 that are located on the membranes of cells in organs throughout the body. When these receptors are bound up by cannabinoids of different kinds, they will affect the biochemistry of these cells, which will affect our overall physiology. The sources of compounds that activate these cannabinoid receptors are three. Phytocannabinoids come from plants. Endocannabinoids are ones that we synthesize ourselves and will bind to these receptors. And then synthetic cannabinoids, both agonists that stimulate the receptors and antagonists that block the specific receptors, can be made in the laboratory, and they can be they're directed to specific receptors. They potentially are therapeutics. So far, they haven't been tested that way. Mostly they're used as research drugs. Another important thing about cannabis pharmacology, and we'll deal with this in more detail soon, are routes of administration. How do we get these cannabinoids into our body? They can be inhaled as smoke from cigarettes or vaporized, or they can be taken orally as liquids or as edibles. And there are different formulations, and there are different dosing patterns, and this produces certain complications. The cannabinoid receptors, as you can see in this diagram, are located all over the body, in the brain, in the lungs, in the blood, in muscles, in your GI systems, in your genitals, in the immune system, importantly, something that controls inflammation, in bone marrow and pancreas. CB1 and CB2 receptors are often found in the same organ, although on different cells, and they seem to have different effects when they're activated. Now, there's been a problem with cannabinoids for pain for the last 10 years or so, since they were begun to be investigated intensely. Although animal experiments give very positive results for neuropathic pain models and cancer pain in animals, etc., when people have conducted clinical trials, they've gotten quite variable responses. So some trials report strong positive effects, and some trials report no effect at all. And major question is, why is there that difference? What are the factors that produce those differences? Well, probably a major one has to do with dosing. What's given and how it's given. So different routes of administration. People are asked to smoke things, or they're taken, or it's given orally. When you smoke things or you take them vaporized, they're vaporized differently, using different methods, using different temperatures, and the vapor is delivered differently for depending on the duration of inhalation, and that determines what concentration will show up in the blood and what the pattern of that concentration will be. And these things all differ among different studies. There's no standard for giving it. And another problem is that there are different formulations of cannabinoids. There are liquid extracts from plants, but the plants differ in the amount of the different cannabinoids. Some of them will have a very high concentration, or relatively high concentration, of tetrahydrocannabinol, for example, which is a very pharmacologically active ingredient, and it's the one that has the psychoactive effects. Others will have more or less cannabidiol or cannabinol, and these different formulations have been used by different people. And liquid extraction techniques are different, and what's in the extract's different. And then the different doses are given, and they're not given in uniform patterns. So all of these variables are major problems in dealing with cannabinoids. So what are we to do about that? Well, Almog et al. Published a paper in 2020 with very promising results, where they devised a machine that could extract in a very constant way tetrahydrocannabinol and other cannabinoids from a plant material that had a very constant, consistent composition of cannabinoids. And in this study, they studied, I think, 25 or so patients who had constant chronic pain, some from diabetic neuropathy and some neuropathic pain from nerve injury. And they took blood samples regularly after the inhalation. And the machine was designed to give a constant inhalation pattern, regardless of the breathing pattern of the people. It was the output was controlled by a computer. They measured blood levels and had very consistent changes. There was only a few minutes during which the material was inhaled, and then the blood levels peaked at about 5 minutes and had fallen down to baseline levels after about 15 minutes. But the pain relief was remarkable. These people reported pain on a scale of 7, where 10 is the worst possible pain and 0 is no pain. And it went from 7 down to around 4, consistently about a 50% decrease in pain just from this one experience. And importantly, even though the cannabinol levels in the blood had fallen down to baseline levels by 30 minutes or less, the pain relief had persisted for 2.5 hours, and they didn't do measurements after that time. That was the duration. So studies of longer duration are certainly underway, and this is very promising. So important messages here is, if you control the dose, the amount that you're given, how you're giving it, and what blood levels to achieve. And by the way, these blood levels were quite a bit lower than what other people had used with less effective results. And the psychoactive elements reports from these patients were very modest, and they resolved very quickly within an hour or two after the thing. So if you can control the dose, you can get a good analgesic effect on chronic pain without having these adverse side effects. Keep an eye on this group. Okay, what are the other solutions to improve cannabinoid effectiveness? Well, one of them is, instead of being given systemically, that is, so that they go in the blood and then they get delivered to these other organs, particularly to the brain and the peripheral nervous system, they can be applied directly to a diseased organ. For example, a kidney that has cancer could be injected with cannabinoids directly, or the blood that's going directly to the kidney could have it delivered that way. So it's not circulating around the whole body. The dose is very well controlled, and the delivery route is there. One could even have a catheter and deliver it slowly, or have it bound to some particles and have it be stimulated release, for example, by some kind of radiation. So direct application. A second approach is to use different drugs. People have looked mostly at cannabis and cannabis-related compounds, but there are other compounds that are found in the same plants, for example, flavonoids, and they act on different receptors, not on cannabis receptors, and they're effective as anti-inflammatory agents and analgesic agents and anti-cancer agents. So if we look beyond cannabinoids, there may be some other areas of great promise. And a third, and there's been some modest success with this, is to elevate the actions of endogenous cannabinoids. So our bodies are making cannabinoids, anandamide, for example, is one, but our bodies also have enzymes that break those down. So they don't stay around for very long. But we know of certain inhibitors of those enzymes, those degradative enzymes, and if the breakdown is inhibited, then the synthesis will continue, and higher levels and persistent levels of endogenous cannabinoids can occur. And a fourth is to combine different therapeutics to what's called polypharmacy, to direct activation or inhibition of different targets so that you get a synergistic, more than additive effect. So what are the challenges? What are our expectations, and where are our hopes for cannabis, and in fact for dealing with chronic pain at all? Well, one of the things that's important to recognize is that individuals vary a lot in their response to drugs. Their receptor distributions may vary. The coupling of those receptors in different organs may vary. It's very well known that pharmacokinetics, how we metabolize drugs, varies greatly among individuals in a way that's genetically determined. And so there may be responders in a broad population to drugs and non-responders. And so different approaches for different individuals is important. And this is the example of personalized medicine, which will make things better for people and have fewer side effects. A second thing is to realize that personal, familial, and social factors contribute to chronic pain. And so multidisciplinary treatment programs are important. That is, an individual has chronic pain, may be getting a drug to help reduce it, seeing a therapist, having occupational therapy, having physical therapy, maintaining social activities, etc. And multidisciplinary therapy is the standard for the treatment of chronic pain. I can't emphasize enough how important expectation is. If people expect that something's going to work, it more often works than not. And when this is true in drugs, it's what we call the placebo effect. People who are told that they're going to get a positive effect, they're going to get an effective pharmacologically active ingredient, but they don't get it, still have a positive response. They still have a reduction in pain. And amazingly, even when they're told that they got the placebo, they still continue to have a positive effect because they expect to have a positive effect. And unfortunately, the opposite is true. If they expect that something's not going to happen, or that a bad thing's going to happen, then a bad thing's happen. So our expectations have a lot to do with how we deal with pain. And of course, we recognize that our expectations also have a lot to do with how we deal with all the aspects of life. Self-care is an approach that was developed not by physicians, not by researchers, but by chronic pain patients. They took the reins for their problem. They developed a program where they remained active, physically active and vocationally active. They kept their jobs, even though they had some pain. But they didn't let the pain stop them from functioning. They didn't isolate themselves socially. They kept their relationships up. Yes, it was uncomfortable, but they were willing to accept that in order to maintain their function. And in general, they're not only satisfied, but happy. And yes, are they in pain? Yes, but it hasn't destroyed their lives. They've got the support of their families. They often meet together in groups. They have therapists, they can call it. There are programs that they have on a computer that they can work on with a whole month, for example, and then check in with the therapist. It doesn't have to be something that's daily. They might have their drugs adjusted, but the point is that they've taken the responsibility for their lives. And it's impressive, I believe, that in group therapy, this has been good. When people are having a really hard day, pain is really severe, they can call up a member of the group and they can talk and they can get support. They can get empathy, and that helps in the healing. So it's not a cure, but it sure makes things better. And that's an example of the fact that there is hope when we work together, when we help each other out, when we are in a caring community. And after all, we're all in this world together. Thank you.